concepts of CPT coding. So if you felt that it's all been difficult up until now, surprise! I am going to give you a lot of tools that you can use that will make this process more simplified. Out in industry, evaluation and management coders actually, it's kind of a twofold type situation, because if the documentation isn't there appropriately, you could spend a lot of time trying to track down or get the information that you need. So there's a lot of things that coders can do to simplify the process to a degree. And when you're querying physicians, it's somewhat, when you're talking evaluation and management, if that's a coding service that you, or a coding function that you want to provide for a healthcare organization, you make more money, number one. But you ultimately train the physicians in how to document to get the bang for their buck. It's you know, it's lucrative on both aspects. If it wasn't documented, it wasn't done. And if it wasn't done, guess what? The healthcare organization isn't going to be reimbursed for those services. There's a number of places that you can look in a patient's medical record to abstract the information you need for evaluation and management coding. Again, this is where that super bill comes into play. Or in a lot of cases, from my experience, they'll jot down on the record. Now, one thing that you have to consider is a lot of coders that do physician service coding will do the EM coding as well. So some of these outside little organizations that do physician coding, is anyone familiar with that? And some healthcare organizations do that. Barry Lindman Group. Has anybody ever heard of Barry Lindman Incorporated? They, it's essentially pretty much all remote coders, and they'll do the coding for physicians. The physicians are the ones who bill the EM services, not the hospital. We all know this, right? Kind of like the anesthesiologist codes their services, not the hospital. This is another one of those examples of coding functions or coding services that are coded by the provider that's providing the service rather than the hospital. There's a couple of healthcare organizations. When a physician works at a hospital, they're credentialed. They have privileges. They're not hired as an employee at the hospital. Is everyone aware of that? They are actually have to go through a lengthy process called credentialing, where they are granted certain privileges within a healthcare organization by the medical director, and each hospital has what they call bylaws. And those bylaws actually stipulate the level of degree or what's required of that healthcare provider. Documentation is one of those requirements of the provider. Some healthcare organizations, when we now have ACOs, does anyone know what an ACO is?
Healthcare organization.
Thank you. Accountability is becoming huge with the changes that are on the forefront with reimbursement and, of course, other more accountabilities put on the healthcare organization to manage waste, provide quality care. So a lot of these healthcare organizations now, the ACOs, accountable care organizations, are starting to actually hire the physicians full-time, 40 hours, because they reduce burnout. They are also, can kind of have that employee more homegrown for the healthcare organization. So some evaluation and management coding is beginning to be performed in the healthcare organization. But it's just kind of food for thought, because as I had mentioned, this is ultimately the most complex part of CPT coding.
The credentials, do they have to be like renewed every 2 or 3 years?
Yeah, it's a biannual process, so it's done every 2 years. A lot of HIM professionals actually do the credentialing as well. Either that or they have a credentialing coordinator that will perform these functions. But you go in and you have to actually obtain all of the licensure kind of like, it's almost like an HR function. Now, HR would manage all of the nurses, all of the, I want to say they're not licensed independent practitioners. So they would be in charge of, staff that is hired by the healthcare organization. But then the credentialing expert takes all of the data, the licensing, DEA, they take everything. They have to do the background checks. They have to do a variety of, there's secondary and primary sources that have to be checked, because you're not only looking in one place, you have to look in two places. There's a lot of Joint Commission standards, but that is a function that a lot of HIM professionals perform. So it's fun, but you have to double check it every 2 years, and then they have also what they call peer review. So the medical director, they're actually like scoring and evaluating the other practitioners within the group. So it's kind of it's a busy process. I know at one of the skilled nursing facilities where I worked, the LIPs that I had to credential, of course, it's any outside provider coming in and providing services. And there was one that was a PA type of a healthcare organization, so they had the physician assistants come in, especially on weekends. So it was on the North Shore, and essentially we were talking with this group, and it was, okay, there could be 12 different practitioners coming in. So it was like, okay, wonderful. And then in looking into it a little bit more, because it was like I'd be checking the charts on a Monday and stuff, and it would be like, I don't recognize this doctor's name. I don't recognize this, so it was kind of like a little bit of backtracking, because they have to be credentialed in order to provide services. It's almost like someone saying, well, I'm a dentist, but I want to be an orthopedic surgeon. So they have to be granted those credentials, and it's part of the Joint Commission process. So in looking into it, and of course I opened a huge can of worms, because it ended up that I had to credential 600 people for that one healthcare organization. Because instead of it being 12 people that may possibly come in, it could be more than 600, where it was the entire North Shore and regional. So it was, and that's just one group. If you think about it, most healthcare, even physicians now have groups, right? I mean, you're seeing networks, and you're seeing, so yes, every provider at each of those organizations have to actually be granted privileges. And that's one thing with the documentation, is sometimes if that documentation isn't completed in a timely manner, which of course, it's essentially 30 days, which is by regulation. So if it's not completed within the 30 days, a lot of healthcare organizations turn around and say, guess what, we're holding your paycheck. You're not getting paid until you come in and you take care of your charts. And they can legally actually do that because it's not an employee. Everybody see that?
So, as my daughter had her foot surgery at CMC, but the doctor that provided it was at Dartmouth was a Dartmouth Hitchcock doctor, so he gets credentialed at Dartmouth Hitch, but then also at CMC, because that's what he's practicing there as well, providing surgery.
Exactly. So if you're in multiple networks, you are credentialed by multiple credentialing.
And he's probably at the Elliott potentially too, if he's providing service there as well, right?
Yeah. So that's a full-time job in itself. But let's take a look at evaluation management. Because this is kind of a tricky aspect when it comes to CPT coding. Of course, the idea behind any type of coding is to optimize a service but never maximize it. We don't want to upcode, we don't want to undercode, because both raise red flags. So we want to match up our documentation, of course, the best we can to our patient's health record and determine what the most appropriate code to apply is.
Can physicians code their own records?
Some do.
Yeah.
But as a coder, it's our ethic responsibility it's our ethic responsibility to make sure that the documentation supports the code that they assigned. Because a lot of the times what physicians, when they do their own coding, or if it's a super bill, the elements still need to be there. If the elements aren't there, and I'm gonna let you know what those elements are, but if those elements aren't there, and you can kind of go through and you can pull them out, you can abstract them fairly easily. But it's, again, a checks and balances type practice where a lot of the physicians before, I know one of the things that I had to do at one of the healthcare organizations was actually on the initial patient assessment report is add, a form field for duration, or have it so that they could circle 15 minutes, 30 minutes, because this is one of the time components in evaluation and management, time component. Do you know how many, on a Monday morning when a physician comes in after the weekend and they've had 29, and I'm going lowballing here, but 29 admissions over the weekend, and they're coming in and there's only 2 physicians, and they got to make rounds, and they've got all these new patients, and they're getting all the information from the staff that was, bits and pieces. Do you think that they're going to take a moment and write down, let's see, I just spent 30 minutes with this patient? Not necessarily, because they're going boom, 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 boom. And when you're talking about having somewhat of a shortage in healthcare providers, that documentation, that's why I said it's up to you as a coder to train that doctor in the appropriate way. If you see a certain physician, because some of them are really great. Some of them will give you all the information that you need because they're seasoned. Others, you got to marinate a little bit. You got to season them. You've got to show them the appropriate way to do it so that they will, in turn, document the way you need them to. So you can code appropriately. I've said it multiple times, but of course they want to be paid for their services. They want to make sure that they're being reimbursed when they should be being reimbursed. There's different levels of skill that are required to provide these types of services. They should be compensated appropriately, right? Okay, so there's 3 factors of evaluation and management coding. We have the place of service. Of course, that's the healthcare setting. We have the type of service. Was it a consultation? Was it an evaluation? Was it a counseling service? What type of service was it? And then we have the patient status. We're going to look at each of these as we go through tonight's lecture. So again, the place of service could be your healthcare setting. Where is it? Is it an emergency department? Is it a nursing home? What type of, or even home health services we have evaluation and management codes for. The type of service, again, admission, consultation. There are some prolonged services as well. There may also be, if a patient is held on observation, evaluation and management codes may apply to that. Patient status, we have a new patient, we have an established patient, and then we have outpatient and we have inpatient. How would you best describe an inpatient? A person who has been formally admitted to a healthcare organization. Someone whose outpatient is considered ambulatory. They're still walking. They're not in a bed yet. So, okay. So a new patient is someone that has not been seen by a provider or anyone within that group or the same type of specialty within 3 years. Okay? New patients, of course, because they do not have a medical record yet established with that provider, they don't have a medical record. There is no medical record easily accessed, so it takes a lot more time with a new patient because you have to establish all that information, right? You have to go through and get past medical history. You got to get, if you think about it, you got to get a lot of information on that initial visit. An established patient is a patient who has been seen by a provider or someone within that group within 3 years. They already have a medical record. They're familiar, so they have been seen. Of course, outpatient is A person who has not formally been admitted, and an inpatient is someone who has been formally admitted. So the levels of the evaluation and management services are based on 6 different steps. We've got the nature of the presenting problem. That's essentially the foundation of evaluation and management coding. We have the skill required to provide a certain service, the time that was spent with the patient, that's that time factor that I had mentioned, the level of knowledge necessary to treat the patient, effort required, and responsibility required. Can everybody see how resource is highly indicated here? Okay. So we have some key components and some contributory factors that make up the different levels of evaluation and management coding. And each of those levels pretty much are made up of varying factors of both those contributory factors and the key components. So of course, if you have an encounter that has a high level of each component, you have a higher level of service, right? And if you have a visit that has a lower level, then you're going to have a lower level of service, right? I got a great example for you. So our key components are, of course, our patient history, the physical examination, and the level of medical decision-making. Our contributory factors are, of course, the counseling involved, the coordination of the care, and the nature of the presenting problem for the patient. When we have a patient's history, there's 4 components to a patient's history. Okay, this is where those different counting little levels start coming in. So we have 4 elements of history. A chief complaint. Does everyone know what a chief complaint is? It's subjective. It's the patient's own words. When they come into their healthcare organization, it's essentially written. The chief complaint is written in the patient's words. The history of the present illness, our review of systems, and our past family and social history. So those are our 4 elements of history for a patient. If you are a new patient, of course, when you go in for that initial visit, you're going to have all 4 of these components completed, right? Because the physician needs this information. Now, if you go in because you have a sore throat, are they going to have to do a past family social history on you? They already got that information, right? So they wouldn't necessarily have to go to that extent, or they wouldn't have to do a complete review of systems either, would they? So, in those 4 elements, in our chief complaint is subjective, this is required for all levels of services. So if any service is performed, there has to be a chief complaint, otherwise you wouldn't be going to see a provider anyway, right? Our history of present illness. We actually have 8 elements to this. And I'm going to list the 8 elements. This is counting involved in CPT coding. These are 8 components where we're going to say, okay, do we have 2 out of 8, 3 out of 8, 4 out of 8, 6 out of 8, 8 out of 8. This is one of those counting components, I'll call it. So we have location,